What do you think about this fly? Do you have any idea about this fly? This is called dragonfly. बचपन में हम इसे हेलीकॉप्टर कहते थे, धागा बांध के उड़ाया करते थे। ड्रैगन फ्लाई चंद ममालिक में इनकी अफसाइश की जाती है, क्योंकि जो आज हम डिस्कस करने जा रहे हैं, डेंगू फीवर, जो डेंगू मच्छर है वो ड्रैगन फ्लाई की मरगूब गज़ा है। लेकिन अफसोस से कहना पड़ता है कि जो हमारे यहाँ अंधाधुंध स्प्रे किया जाते हैं, जहाँ से डेंगू मच्छर तो मारा जाता है, इसके साथ जो ड्रैगन फ्लाई भी खत्म होते जा रहे हैं। अशरतुल अर्ज़ हमारे 5 करोड़ साल पुराने साथी हैं। इनके आत्मे के लिए जो स्प्रे किए जा रहे हैं वो खुद इंसानों के लिए इंतहाई खतरनाक है। डेंगू मच्छर ड्रैगन फ्लाई की मरगूब गज़ाए अंधाधुंध स्प्रे ने मच्छर से ज़्यादा ड्रैगन फ्लाई को नुकसान पहुंचाया है। This is picture of aedes aegypti. Today we are going to discuss about dengue fever. I am Dr. Khalil. The content we discuss: definition, classification, investigation, diagnosis, management, and prevention. Learning objective for today's session: at the end of this presentation, you will be able to investigate, diagnose, and manage a case of dengue fever at bedside. What is the definition? Dengue is an acute systemic illness. It is caused by dengue virus of genus flavivirus and spread by female aedes aegypti mosquito. There are 4 serotypes of dengue virus. All these 4 serotypes are single-stranded RNA virus, and all are transmitted mainly by the aedes aegypti mosquito. Infection with one serotype does not confer immunity to the other serotype. Diagnosis of dengue: there are 2 methods for diagnosis of dengue. One is clinical, other is the virological method. Clinical diagnosis: remember that dengue is suspected clinically on the basis of high-grade fever with chill, body ache, myalgia, arthralgia, retroorbital pain. Clinically, we are going to suspect any patient presented with the high-grade fever with chill, severe myalgia, arthralgia, headache, and retroorbital pain. Always suspect dengue in the endemic area. And sometimes patient may be presented with the severe symptom such as ecchymosis, GI bleeding, epistaxis. These actually appear in case of severe dengue fever. Very important, malaria and enteric fever must be ruled out in the endemic area. Wherever you are suspecting dengue fever, you must rule out malaria and enteric fever, because the early clinical sign and symptom of dengue fever is always non-specific. So you must rule out malaria and enteric fever wherever you are suspecting a case of dengue fever. Is it clear? Dengue symptom, fever with any of the following. Patient may be presented with a headache, nausea and vomiting, body rashes, retroorbital pain, muscular pain, bony pain and joint pain. Any patient with the fever presented with any of these symptoms, always suspect dengue fever in the endemic area. Rashes of isolates of white in the sea of red in the dengue fever. These are the characteristic rashes of dengue fever. Erythematous rashes. This is called isolates of white in the sea of red. Let us discuss about the level of severity. As we are discussing the clinical diagnosis, according to WHO 2009, WHO classified dengue fever on the basis of severity. First is the probable dengue. Second, dengue with warning sign. Third, severe dengue. What is the probable dengue? If there is any history of traveling to the dengue endemic area, or some patient residing dengue endemic area, or travel to dengue endemic area, having history of fever plus 2 of the following criteria. Patient having fever, maybe with nausea and vomiting, body rash, ache and pain, tourniquet test positive, leukopenia. This is called probable dengue. Dengue with warning sign means patient presented with the abdominal pain or tenderness. Patient having fever with abdominal pain and tenderness, persistent vomiting, clinically fluid accumulation, and mucosal bleed, ecchymosis, GI bleed, epistaxis, lethargy, restlessness, maybe there is hepatomegaly, liver enlargement greater than 2 centimeters. And laboratory, there is increase in hematocrit concurrent with rapid decrease in platelet count. CBC shows increase hematocrit level and decrease platelet level. This is labeled as dengue with warning sign. Severe dengue means there is evidence of severe plasma leakage. If the patient presented with the shock, dengue shock syndrome, If the patient presented with the fluid accumulation with respiratory distress, this is type of severe dengue. If the patient presented with the severe bleeding or severe organ involvement, such as the liver, AST or ALT greater than 1000, CNS, there is impaired consciousness, and heart and other organ involvement. If there is evidence of severe bleeding, if there is evidence of a shock, if there is evidence of fluid accumulation with respiratory distress, its level is severe dengue. Is it clear? Why we classified on the basis of severity? What is the important? Because depending on the clinical manifestation, patient may be classified into one of the following three management group. Group A mostly included probable dengue. Probable dengue, group A can be managed at home. Group B need an hospital management. Probable dengue, dengue with warning sign, dengue with warning sign in the group B. It should be managed in hospital setting. Group C include severe dengue. It need emergency management. Is it clear? On the basis of on the level of severity, we are classifying into three categories. And on the basis of these clinical manifestation, we are dividing into three groups for management purpose. Is it clear? Group A, as we discussed previously, you can manage it at home with the oral fluid, with the paracetamol. Group B, especially with the warning sign, you will manage in the hospital setting. You manage it with the IV fluid. While group C, that is the severe, you can manage it in the ICU setup. What do you mean evidence of plasma leakage? How we come to know there is evidence of plasma leakage? जिस तरह अगर हमें पता चले किसी को डेंगू है, मोस्टली जो पेशेंट है और उनके रिलेटिव हैं वो पैनिक हो जाती है। हालांकि इसमें पैनिक होने की कोई बात नहीं है। फर्स्ट यू हैव टू सर्च आउट एविडेंस ऑफ प्लाज्मा लीकेज। Evidence of plasma leakage caused by increased vascular permeability manifested by at least one of the following. If there is increase in hematocrit greater than 20%, above average for age and sex, if the hematocrit is increasing above 20%, it indicates plasma leakage, evidence of plasma leakage. And decrease in hematocrit after volume replacement treatment greater than 20% of baseline. If you start the treatment with the IV fluid management, because there is plasma leakage, you manage the patient with the IV fluid. उमूमन हम यही कहते हैं कि प्लेटलेट देते हैं, प्लेटलेट देना नहीं चाहिए। प्लाज्मा लीकेज यू गिव द आईवी फ्लूइड। जब आपने आईवी फ्लूइड दे दिया, वॉल्यूम रिप्लेस किया, तो इसकी हेमाटोक्रेट जो होती है डिक्रीज हो गया ग्रेटर देन 20%, जो पहले जो शुरू में 20% इंक्रीज था. Sign of plasma leakage such as pleural effusion, ascites and hypoproteinemia is also are evidence of plasma leakage. Is it clear? तो फिर प्लेटलेट हमें कब देना चाहिए, किन कंडीशन में देना चाहिए, तो उसे हम बाद में डिस्कस कर लेते हैं. अब वायरोलॉजिकल डायग्नोसिस पहले हमने डिस्कस कर लिया कि क्लिनिकल डायग्नोसिस. लेट अस डिस्कस वायरोलॉजिकल डायग्नोसिस. वायरोलॉजिकली we will do the dengue NS1 antigen. It identify dengue antigen by ELISA. NS1 antigen, it is highly specific. There is no false positive. It is positive from 1 to 7 days. If on first day is negative, repeat it on the next day. Is it clear? Second investigation, anti-dengue antibodies. If anti-dengue antibody positive IgG and positive IgM, if both antibodies IgG and IgM both are positive, it suggests secondary dengue infection. These patients are more prone to complication. If there is only positive IgM but not positive IgG, only IgM is positive, it suggests primary dengue infection. We also do dengue PCR. Virus is recovered from the blood by PCR, not for clinical purpose, it is for research purpose. Dengue PCR is a test for researcher, not a test for clinician. We will do it for the research purpose. This is immature platelet fraction IPF. जिस तरह हमने पहले बता दिया था कि प्लेटलेट कब देना चाहिए, क्योंकि जो डेंगू का मरीज़ आते हैं वो उनके अटेंडेंट फैमिली सारे शॉक में होते हैं कि अब ब्लीडिंग शुरू हो जाएगा, अब हमें प्लेटलेट की बंदोबस्त करना होता है. और कुछ लोग ऐसे भी होते हैं कि डेंगू मरीज़ को शुरू से प्लेटलेट ट्रांसफ्यूजन शुरू कर लेते हैं. ऐसा नहीं है. इमेच्योर प्लेटलेट फ्रैक्शन, जब भी प्लेटलेट की डिस्ट्रक्शन होती है तो हमारे पेरिफेरल सर्कुलेशन में इमेच्योर प्लेटलेट आना शुरू हो जाते हैं. इमेच्योर प्लेटलेट फ्रैक्शन एनालाइज्ड बाय स्पेसिफिक blood machine, by blood analyzer. These are the young immature platelet. जहाँ भी पेरिफेरल डिस्ट्रक्शन हो रही होती है तो इमेच्योर प्लेटलेट आना शुरू हो जाती है. तो हमें इनकी फ्रैक्शन मालूम करना होता है इन परसेंटेज. आपने मरीज़ को अटेंड कर लिया, मरीज़ का CBC करवा दिया, प्लेटलेट काउंट 20,000 है, हम उमूमन क्या कर लेते हैं, प्लेटलेट ट्रांसफ्यूज कर लेते हैं. इट इज़ नॉट जस्टिफिएबल. अब प्लेटलेट काउंट 20,000 है लेकिन इमेच्योर प्लेटलेट फ्रैक्शन टेस्ट आपने करवा दिया, इट इज़ ग्रेटर देन 10%. व्हाट इज़ द आउटकम? Patient is out of danger and platelet will rise in 24 hours. No need platelet transfusion. Platelet transfusion की ज़रूरत नहीं है. Just give IV fluid. Is it clear? अब if the platelet count 20,000 and immature platelet fraction 6%, repeat the same next day. No need platelet transfusion. you have to repeat the same next day. If immature platelet fraction increases to 8%, पहले सपोज ये 6% था, अब इंक्रीसेस टू द 8%, लेकिन अभी प्लेटलेट काउंट अभी तक 20,000 है. Platelet will certainly increase within 48 hours. No need to transfuse platelet. If immature platelet fraction less than 5% and platelet count 20,000, bone marrow will not respond for 3 to 4 days. May be a likely candidate for platelet transfusion. Is it clear? तो कहने का मतलब यही है कि platelet transfusion does not depend on the platelet count. Platelet transfusion depends on the immature platelet fraction. If it is less than 5% immature platelet fraction, bone marrow will not respond. For 3 to 4 days, you have to transfuse platelet to your patient. Is it clear? तो एवरी डेंगू पेशेंट को हम प्लेटलेट ट्रांसफ्यूज नहीं कर लेते हैं, चाहे उनकी प्लेटलेट काउंट 20,000 क्यों ना हो. How will you manage a case of dengue fever? There are 3 steps. First is the bed rest. Let your patient rest as much as possible. Bed rest. Second step, control eye fever with the sponging, with cool water. Give paracetamol, acetaminophen every 6 hourly if needed. Avoid NSAID in case of dengue fever. The third is to prevent dehydration with oral or IV fluid according to the level of severity. And don't give ibuprofen, aspirin or aspirin containing drugs. जो दाना लोग होते हैं वो हमेशा कहते हैं कि प्रिवेंशन इज बेटर देन क्यूर. प्रिवेंट स्प्रेड ऑफ डेंगू इनसाइड योर हाउस. कौन सी प्रिवेंशन हमें लेना चाहिए? मॉस्किटो that bite the affected family member can go on to bite and infect other. जो डेंगू का मरीज़ हैं उन्हें मॉस्किटो नेट में रखते हैं, उन्हें आइसोलेट कर लेते हैं, सेपरेट रखते हैं कि ऐसा ना हो कि कोई दूसरा मच्छर ऐसी इन्फेक्टेड बंदे को काटे और दूसरे को इन्फेक्ट करे. Allow the sick child or family member to rest and sleep under a bed net. Or use insect repellent while feverish. Kill all mosquito in the house, empty container that carry water. Place screen on windows and door to prevent mosquito from entering the house. These are few preventive measures you can take. Is there any vaccination? Yes. Vaccine, it is a live viral and it is approved by the FDA in 2019. लेकिन उन लोगों के लिए अप्रूव किया गया है जिन्होंने प्रीवियसली डेंगू इन्फेक्शन हो गया हो, क्योंकि इट इज लाइव वैक्सीन. आप प्रीवियसली डेंगू इन्फेक्शन confirmed previously dengue infection who live in dengue an endemic area, you will advise for vaccine. And especially for individual age 9 to 16 years जिन्हें प्रीवियसली एक बार डेंगू फीवर हो चुका हो और वो लेबोरेटरी कंफर्म हो, तो आप तब उन्हें वैक्सीनेशन कर सकते हैं। सही। अब ये जो वैक्सीन है ये एलिसेट डेंगू स्पेसिफिक इम्यून रिस्पॉन्स अगेंस्ट ऑल 4 डेंगू वायरस। सही है, सेरोटाइप 1, 2, 3 एंड 4। सही है, डेंगू वायरस, सेरोटाइप, ऑल 4 वायरस। और immunization is a series of 3 subcutaneous injections administered 6 months apart.